Good afternoon, everyone. I'm Titis K, a PhD student from Faculty of Nursing, Prin of Songkla University, Thailand. Today, I would like to share part of my thesis work entitled Disabling Practices for Diabetic Patients with Comorbid Disease, an ethnographic study. This project I conducted together with both of my advisors, Associate Professor Dr. Kitty Konil Manat and Assistant Professor Umapon Banya Sopun. And this is my coverage of presentation today. And our study focused on disabling practices for diabetic patients with comorbid diseases because admit to and discharge from the hospital can be a very crucial life event from this patient group. Diabetic patients identified have double risk for hospitalization compared to those without diabetes mellitus. They also identified have 10 to 26% for unplanned readmissions. Unfortunately, some studies in some countries also found a significant numbers of other chronic diseases among diabetic patients that further increase the risk for hospitalization and unplanned readmissions, as well as increase the complication incidence, increase the complexity of self-management practices, and deprive patient prognosis, as well as mortality rate and quality of life. Hospitals actually have discharge planning program to facilitate patients smoothly discharge from hospital and manage their chronic condition at home. However, even though this program is effective, but the studies also found that discharge planning practice is complex work involving wide range of healthcare professional staff as well as various hospital resources. Nurses in particular, as the discharge planning provider, experience many difficulties and barriers due to the time limitations, time constraints, unclear guideline, as well as lack of coordination between staff in conducting discharge planning practice. On the other hand, patients with diabetes mellitus also experience many difficulties to manage their chronic condition after discharge from the hospital. These both available evidence explore discharge planning practices from single perspective, either provider or the receiver. Thus, our study conducted to explore further from both sides to gain better understanding related to discharge planning practices, particularly for patient diabetes mellitus patient with comorbid diseases. For achieving those purposes, we applied ethnographic study at a tertiary top referral system and teaching hospital located in Bandung, West Java, Indonesia. We applied three types of data collection method, including participant observation, online in-depth interview, as well as document review to various type of participants, starting from nurses as uh, the point of uh, observation and interview. Then we extended to surrounding healthcare professionals that involved in discharge planning practices, such as physicians, nutritionists, pharmacists. We also include patients and their family to explore their experience receiving discharge planning practice from those healthcare providers. After 7 months data collection procedure, we achieve the saturated data consists of 23 interview transcripts, 13 observational field notes, as well as 5 conversation notes. Then we run content analysis procedure following ELO and KINGAS. And we also apply several strategies to maintain the trustworthiness of our study, namely prolonged engagement, the briefing, member checking, triangulation, as well as tick descriptions. This is the general profile and demographic data of our healthcare professional participants. Most of them had been working in this world for more than 5 years. Although they worked for that long, most of them reported that they never joined any training discussed about discharge planning practice. Most of them are Muslim, live from Sundanese cultural group, as the ethnic group, the biggest ethnic group live in West Java. And the other participant is patient and family. We included for patient family. Two of the patients admitted to the hospital due to diabetic-related complication, while other two admitted to the hospital due to other chronic condition. Most of them hospitalized within 1 week's period, and they discharged from the hospital with improvement status. From the analysis, we found two main themes. The first theme is discharge planning activities, covering 4 main activities, starting from assessment, discharge planning assessment, then patient and family education, discharge planning decision, as well as discharging patient from the hospital. The second theme is discharge planning practice characteristic, covering 8 categories, starting from unplanned practice, medical signal practice. We observe that discharge planning practice in this hospital started when patient almost discharged from the hospital. They did not have certain planning start from the beginning of hospitalization period, and mostly they start of discharge planning practices once the discharge decision made by physician in charge. And the third characteristic of the discharge planning practice is follow the living guideline. In this hospital, they have written guideline, but then participants reported that they never read, never learn about this guideline. Rather, they follow the spoken guideline, instruction, direction from the ward nurse, the head nurse and vice head nurse. They give some explanation and direction how to perform discharge planning in this ward. We also found that discharge planning performed by various healthcare professionals, including nurses, physicians, nutritionists, and pharmacists. But each of these healthcare provider, they practice independently. No specific coordination and communication to distribute responsibility related to discharge planning practices. The other characteristic is discontinued. After patient discharge from the hospital, there are no other contact interaction between hospital staff and patient. Actually, they have follow-up visit, but then this follow-up visit belong to outpatient department. And what happened during this follow-up visit never reported to inpatient department staff. And the other characteristic incomprehensive. We found that discharge planning practice coverage in terms of education provided to patient and family had limited coverage. Topic like insulin injection, wound care. They did not touch other thing that is very important for patient, like monitoring blood glucose or other self-management components. The other characteristic is persistent practice. We conduct data collection before pandemic and during pandemic, so we can compare those both data. We found that discharge planning practice is conducted quite similarly, except some adjustment during pandemic era. The nurse minimized the interaction and shortened the duration of education with patient. They also minimize the social activity with patient to minimize the risk of cross infection during pandemic situation. And both sides, healthcare provider and receiver participant, confirm that discharge planning practice that they conducted in the hospital is well practiced. Nothing to disappointed about this practice. Our study confirmed that discharge planning practice exists in some extent. And we also confirmed the previous finding that nurse experience lack of knowledge related to discharge planning practice. And discharge planning practice found to be a complex work because it's involving various healthcare professionals as well as hospital resources. And in our study, the nurses in particular, they have experience difficulty in terms of assessing the discharge need because the form they use considered very broad, not specifically representing the patient condition in the end of hospitalization period. While physicians also have difficulties to predict how many days patients will be hospitalized because most of patients admitted to this hospital have multiple diagnoses. So it's difficult to predict certainly in how many days patient will be discharged from this hospital. We add some insight, like clarifying the suboptimal status of discharge planning practices. We found some characteristics that may meet the suboptimal practice, like unplanned, incomprehensive, and discontinued. We also clearly defines at least we found 4 healthcare providers involved in discharge planning practices. Since no study is perfect, we also find limitation in our study, particularly related to participant coverage. Because of this hospital is teaching hospital, many health science students involved in providing care, including planning practice. But during data collection, because most of data collection conducted during pandemic situation, no health sciences student practice in this one, so we cannot include this type of participants. During pandemic situation, also very low number of patients admitted to the hospital, so we have limitation in terms of recruiting the various characteristics of patient participant. We conclude that discharge planning practice in this ward, in this hospital covering 4 activities: assessment, provide education, discharge decision, as well as discharging patient from the hospital, that characterized with unplanned, incomprehensive medical signal, independently practice, discontinued following living guidelines, persistent practice, and perceived as good practice. And with these results, we recommend at least 3 things that is important to further explore about discharge planning practice with covering wider scope of participant characteristics, as well as we also recommended that there are need for additional effort from the hospital to facilitate nurse and other staff learn standardized discharge planning practice, particularly for patients with diabetes mellitus. And it is important also for hospital to build the bridging program, connecting the hospital health services to community health services. Thank you very much for your attention.